My name is Michael Gagno. I'm Senior Director of Pharmacy Practice and Quality with the American Society of Health System Pharmacists. This program is titled Ordering and Administering COVID-19 Therapeutics, with an emphasis on Casirivimab and Imdevimab. None of the presenters today have any relevant financial interest to disclose. The objectives of this presentation are to discuss COVID-19 monoclonal antibodies currently available and their role in the treatment and/or post-exposure prophylaxis of COVID-19, to describe clinical considerations and contraindications for available COVID-19 monoclonal antibodies, and to give examples of infusion or administration reactions to monoclonals and how to respond to them. Note that the content of this program is current as of September 2021. Information on COVID-19 variants and therapeutics, including emergency use authorization indications, is constantly being updated. Please check the ASHP COVID-19 Resource Center, the FDA Emergency Use Authorization website, or phe.gov for the latest information on COVID-19 therapeutics. Our presenters today, including myself, include Catherine Yang, who is a clinical professor at the University of California, San Francisco, an infectious disease clinical pharmacist at the University of California, San Francisco Medical Center. Also joining us is Sarah Edgerly at the University of Kentucky pediatric clinical pharmacist. This program will discuss the PrEP Act amendment that authorized pharmacists, pharmacy technicians, and pharmacy interns to administer COVID-19 therapeutics and pharmacists to order COVID-19 therapeutics, as well as monoclonal antibody clinical considerations, and then observation and emergency response for infusion or administration reactions. But we'll get started with a couple of self-assessment questions. Which of the following are COVID-19 monoclonal antibody indications and route combinations currently authorized under emergency use? A, Bamlanivimab and Etesevimab, given subcutaneously for COVID-19 post-exposure prophylaxis. B, Casirivimab and Imdevimab, given intravenously for COVID-19 pre-exposure prophylaxis. C, Bamlanivimab and Etesevimab, given intramuscularly for COVID-19 treatment. Or D, Casirivimab and Imdevimab, given subcutaneously for COVID-19 post-exposure prophylaxis. The next question is a case: 20-year-old female received a positive SARS-CoV-2 test result from your institution. You are following up on the results to determine if she meets criteria for COVID-19 MAB therapy. Her medical history includes an appendectomy 2 years ago and type 1 diabetes. Should you call the patient to recommend MAB treatment? A, no, she is too young to meet MAB treatment criteria. B, no, her medical history does not make her eligible for MAB treatment. C, yes, a medical history that includes diabetes makes her eligible for MAB treatment. Or D, there is not enough information to determine her eligibility for MAB treatment. And finally, which of the following are potential signs and symptoms of an infusion or administration reaction to MAB treatment? A, wheezing. B, nausea. C, dizziness. D, erythema. Or E, all of the above. By the end of this presentation, you should be able to answer these questions. So let's get started with covering the PrEP Act and the COVID-19 declaration, in particular the 9th Amendment to the declaration. What is the PrEP Act? Well, the PrEP Act is the Public Readiness and Emergency Preparedness Act, and it authorizes the Secretary of the Department of Health and Human Services to issue a declaration in response to a specific health emergency. This is actually different than a declaration of a public health emergency, as these PrEP Act declarations can be more specific and may not rise to the level of a public health emergency. Declarations provide liability protections for manufacturing, testing, development, distribution, administration, and use of medical countermeasures. The COVID-19 declaration for the PrEP Act was issued on March 17th of 2020. And amendments under the PrEP Act allow different authorizations for distribution, manufacturing, testing, developing, administration of some of these countermeasures. And you may be familiar with previous amendments that authorized pharmacists, pharmacy technicians and pharmacy interns to administer full vaccinations, including pediatric vaccinations, and include the COVID-19 vaccine administration. More specifically, the Ninth Amendment, which was recently issued, authorizes licensed pharmacists to order COVID-19 therapeutics, and licensed pharmacists, qualified pharmacy technicians, and licensed or registered pharmacy interns to administer COVID-19 therapeutics. Now, there are some restrictions and criteria that must be met, but it's important to note that this amendment preempts the scope of practice requirements that prohibit qualified persons from prescribing, dispensing, or administering COVID-19 countermeasures. In the case of authorized licensed pharmacists, the therapeutic they're ordering must be authorized, approved, licensed, or cleared by the Food and Drug Administration. And the route of administration must be subcutaneous, intramuscular, or oral administration, according to the FDA authorization or approval. In the case of administering a COVID-19 therapeutic for administration by a licensed pharmacist, a qualified pharmacy technician, or a licensed or registered pharmacy intern, again, the therapeutic must be ordered for subcutaneous, intramuscular, or oral administration according to FDA authorization. But the therapeutic must be authorized, approved, licensed, or cleared by the Food and Drug Administration. For subcutaneous or intramuscular therapeutics, there are additional criteria that must be met. It's specifically the completion of a practical training that includes a hands-on injection technique, clinical evaluation of indications and contraindications of the COVID-19 therapeutic, recognizing and treating emergency reactions to COVID-19 therapeutics, any additional training required under the FDA approval, authorization, clearance, or licensing, and a current certificate in basic cardiopulmonary resuscitation. Note that in the case of a pharmacy technician administering an intramuscular or subcutaneous COVID-19 therapeutic, the pharmacist must be readily and immediately available. The purpose of this program is to cover the clinical evaluation and indications of contraindications of COVID-19 therapeutics, including the recognition and treatment of emergency reactions to COVID-19 therapeutics. The program assumes that participants have completed a hands-on injection technique through an immunization program and already have a current certificate in basic cardiopulmonary resuscitation. Other eligibility requirements for the PrEP Act 9th Amendment include compliance with record-keeping and reporting requirements in respective state, territory, and jurisdictions, including informing the patient's primary care provider when applicable, and also reporting adverse events to the COVID-19 therapeutic. Pharmacists, pharmacy technicians, and pharmacy interns must also comply with applicable requirements or conditions of use that are within the administration of COVID-19 therapeutics, as listed in the Emergency Use Authorization or FDA license. So let's get started with the monoclonal antibody clinical considerations. We'll turn this over to Dr. Catherine Yang, who is a clinical professor of pharmacy at the University of California, San Francisco, and an infectious disease clinical pharmacist at the University of California, San Francisco Medical Center. Dr. Yang specializes in the treatment of multi-drug resistant infections, and her area of expertise is in the pharmacokinetic and pharmacodynamic optimization of antibiotic dosing to potentially overcome resistance and improve clinical outcomes. For the last 18 months, Dr. Yang has redirected her efforts toward the management of COVID-19. She participated in the adaptive COVID-19 treatment trials and is heavily involved with COVID-19 monoclonal antibody programs at UCSF. I'll now turn it over to Dr. Yang.
Thank you, Mike, for having me here today. So before we get started, I thought I would talk first about what it means to be a variant and what is a scariant. So this is a term that was coined by Eric Topol from Scripps in San Diego. And essentially, a variant becomes worrisome when it has three properties. It's infectiveness, increased infectiveness, meaning it's more easily transmissible. It has increased virulence, so it leads to more hospitalizations or potentially death. And it has the potential for immune evasion. And that can be either evasion from say vaccination or your own immune system. So this is a nice infographic from Axios. It's very regularly updated. And this is just shows the 4 variants of concern that are circulating. At the moment, there's only one in the US, and that is this Delta variant, as we've all heard of in the news. But you can see that there are other variants of concern that are floating around the world, and these include Alpha, which was the first variant of concern actually in the US. That was the UK variant. The Beta variant, which is the one that was first discovered in South Africa, and the Gamma variant, or the P1 variant, which was first discovered in Brazil. So thankfully, even though these 4 variants are all considered scariants, none of them have the properties of having all 3 qualities of infectiveness, virulence, and immune evasion. So this is the CDC variant classification system. And since I gave this talk first in May, this classification system has changed considerably. So there is this new classification called variants being monitored. That's this top one. And this refers to variants that no longer pose a significant public health risk to the US. And the remaining 3 variant classifications are the ones the CDC has always had. These include the variants of interest, the variants of concern, and the variants of high consequence. So it goes from the least severe at the top to most severe at the bottom. And as you can see, currently, the only variant of concern, again, is this Delta variant in the US. And these variants are classified on those 3 things that we just talked about: ability to evade the immune system, ability to be treated, and your likelihood of having a poor outcome. So this is this new classification of variants being monitored. So the one thing about the pandemic that I think I've learned is things are changing super rapidly, and variants are coming and going, and variants that we worried about before, we no longer need to worry about now. But unfortunately, now we have new variants that we have to worry about. So variants being monitored refers to variants that clearly have an impact on authorized countermeasures such as monoclonal antibody or vaccine. They are also associated with more significant disease or transmission. But the kicker is they are no longer detected or circulating at very low levels. So essentially, these are variants that used to be either variants of interest or variants of concern. And because they are no longer circulating, they've essentially been downgraded to variants being monitored. And you can see from this table on the right-hand side that we have variants that are essentially moving around in classification. So at the top, you have the Alpha variant, which was the UK variant, and it was initially classified as a variant of concern in late December, and now has been downgraded to a variant being monitored just about a week and a half ago. And this is the same with the Beta variant, as well as the Gamma variant. And interestingly, the last time I gave this talk, we were very, very concerned with what was then called the California variant. And that was this B1.427 or 1.429, which is the Epsilon variant. And that variant, you can see, slowly was downgraded over time, and also now is a variant being monitored. But unfortunately, now the main variant of concern, as we talked about, is Delta. So where do I find information on variants? So when I'm treating my patients, I want to make sure that the drug that I am using is active against the variant that's circulating in my area. So where do I go to find that? And there are lots of different data stored websites that have this information. Eric Topol actually has a great website through Scripps Institute. But I think the easiest place to find this is on the CDC website. So these are a couple of screenshots from the CDC websites showing the variants over time. And on the left-hand graph, you can see the proportion of each of the variants of concern week by week. And as you can see, the Delta variant has really become the predominant virus over time. So the thing to remember about this data, though, this is not based on total isolates. So the CDC has a genomic surveillance system that they use to track variants across the US. However, this is not based on total isolates that are being collected. What basically happens is the CDC receives a sample of variants of samples or isolates from the various health departments at the local and the state level, and they sequence them. And that number of variants or isolates can change week by week based on what each health department sends. So this is based on a proportion of those total isolates that they receive and not on the total samples that are being done in the community. And you can see on the right-hand side that, again, the predominant variant is the Delta variant. So what about in my specific region or state? So there are two places to look for this on the CDC website. They use this system called the Nowcast, and that is the website on the left-hand side. And these orange circles essentially refer to the regions. There are 10 regions in the US that they collect isolates from and will categorize. And you can use the Nowcast system to actually pick a variant, and it will tell you within that circle what proportion is Delta versus Gamma versus Epsilon or whatever. If you want to look specific state by state, there's also a Tableau dashboard that you can do this from. And what I want you to note from this is this does tell you total isolates collected by state or jurisdiction. And you can see from the right-hand side that these total available sequences is really variable. So a state like California sends over 22,000 sequences to the CDC, but then you also have very small numbers sent by states such as Idaho, which only had 658, or Delaware that had 510. So you can see that they cannot report these as total isolates for the US because the number within each jurisdiction is highly different. So this is the reason why they're presented as proportions. So just take that as a grain of salt. So again, the only variant of concern in the US at the moment, because this could clearly change over time, is this Delta variant. So this is the variant that was first identified in India, and it does spread much faster than the other variants. And the data suggests that it can cause more severe cases and even death. The good news is that vaccines tend to be still very effective. All three of the vaccines are available, but breakthrough infections can occur in patients that are vaccinated. So, and that's true for, as you know, for all vaccines, not just COVID. So you can get breakthrough infections even with flu vaccine. But vaccine breakthroughs are in general not that common. And the data does suggest, though, that even in a vaccinated patient, they can still asymptomatically spread virus. So this is still very something to keep track of. So the thing that we want to talk about now is how do our monoclonal antibodies hold up against these variants? This is a table that I took from the NIH treatment guidelines on effectiveness of monoclonal antibodies. And this, you can see, was last updated on September 24th. And this is information that essentially is straight out of the EUA of each of the individual agents. But the nice thing is it has it all in one place for you. If you were to look up this information in the EUAs, you would have to take all the EUAs and put them side by side to look at the in vitro activity. This does a nice comparison for you, so you don't have to do that. The other thing I like about this table is the in vitro susceptibility and activity is presented in more of a qualitative format. So it will tell you there is change or no change and likelihood of activity against clinical disease. This is I think, easier for most people to understand than the EUA, in which it's presented based on a fold chain reduction in susceptibility. So this, I think, is a nice, quick and dirty way to look at it. And you can see here that the only variant that we're talking about, of course, is Delta. And looking at the 3 drugs across, you can see that Bamlanivimab, Imdevimab still is likely to be active. Casirivimab and Subq, both though show pretty good activity in general with no reduction in vitro susceptibility. So here is a comparison of the 4 different monoclonal antibodies that have been EUA authorized in the US. So the thing that I take from this is everything regarding monoclonal antibodies changes on almost a weekly or day-to-day basis. And as pharmacists, we have to be really careful to keep up with this, and it's not easy. So the first drug that came out was Bamlanivimab. That's a Lilly product. This drug was actually EUA authorized on November 9th, 2020, and was the first drug that we started using. This initial product was an IV drug only, and it was only for treatment. Because of the concerns for resistance against the Alpha variant, this product was actually withdrawn from the EUA, was withdrawn by the company on April 16, 2021, in favor of Bamlanivimab, Imdevimab. So we no longer use Bamlanivimab on its own. The second drug to come out was Casirivimab, Imdevimab, and this is the Regeneron product that we always hear about in the news. So this drug was actually EUA authorized on November 21st, 2020. And that was initially authorized for treatment only and at a fairly high dose. That dose is actually no longer being used. And now we have this dose here of 1,200 milligrams total. The initial dose was 2,400. This drug then got a EUA authorization for prophylaxis on August 10th, 2021. So this is for post-exposure prophylaxis. So this drug has 2 flavors of post-exposure prophylaxis. You can do it either as the single dose PEP, which is essentially the same dose as treatment, and that's for high-risk exposures. Or you can do this as an ongoing PEP, where you get a single dose first of the higher dose, and then you get a monthly injection at a lower dose. And this is for ongoing exposures for, say, people who work in an institution where they're chronically exposed. And this is the only product available that has a Subq indication. The third drug that came out was Bamlanivimab, Imdevimab. That again is a Lilly product that came out and was authorized on February 9th, 2021. So this drug, interestingly, was then paused by CDC. The EUA was paused by HHS, and the CDC no longer recommended it, neither did NIH, because there was concern that this product might actually not do well. There might be resistance to actually the Delta variant. So this EUA was paused for about 2 months, and the only drug available at the time was essentially Casirivimab. So then the EUA was reauthorized at the end of August for states where the combined resistance of all isolates was found to be less than 5%. So this is why the surveillance on variants is so important for CDC. And then on September 2nd, this EUA was reauthorized for all states, all 50 states, as well as the territories of the US. And finally, this drug received its post-exposure prophylaxis authorization on September 16th. So this drug only has 1 dose, and that's the 700 milligram of Bamlanivimab and 1,400 of the Imdevimab. And this dose is the same, regardless of whether or not you do it for treatment or single dose PEP. unlike Casirivimab, have an ongoing PEP indication. So it's essentially a one and done. And this drug is also only available IV. And the new kid on the block is Sotrovimab, and this is a Vir GSK product. This EUA was authorized on May 26th, and it's only one dose for treatment only, and it's only IV. So unlike the other three agents, Bamlanivimab, Casirivimab, Imdevimab, and Bamlanivimab, Etesevimab, this drug did not go into the HHS allocation system. So if you want this product, you actually have to buy it from your distributor. So on September 3rd, September 3rd turned out to be a big day. So on September 3rd, because of the diminishing US supply to monoclonal antibodies, HHS actually retook over the allocation process for these agents. So prior to September 3rd, you could buy it, you could just order it through AmerisourceBergen and you could get what you needed. And because there was a large quantity of monoclonal antibodies being used in the southern states, HHS actually took control again of that allocation system and went back to the old sort of remdesivir style allocation of HHS to the state and states to county, et cetera, on a weekly basis. So on that day, the NIH came out with a statement on the prioritization of anti-SARS-CoV-2 monoclonal antibodies because of the risk of shortage. And they basically said that you should prioritize treatment over prophylaxis and also to prioritize patients who are highest at risk for severe disease. And that included unvaccinated or incompletely vaccinated individuals at high risk, or vaccinated individuals where you did not expect to mount an adequate immune response. And these would be patients who were, say, getting chemo at the time they were getting their vaccine. So here you can see the indications for use for Casirivimab and Imdevimab. It has two indications. One is for treatment of mild to moderate COVID disease. And to qualify, the patients would need a positive COVID-19 test. They have to be within 10 days of symptoms, and that's important because the effectiveness of this drug goes down the further you are out from your initial symptoms. You have to be at high risk for progression to COVID-19 disease, and this includes hospitalization and death. The people who do not qualify for this drug include patients who are hospitalized for COVID-19, patients who require oxygen supplementation, regardless if they're hospitalized or not, or patients who have an increased oxygen therapy need due to COVID-19. So for instance, a patient who already has COPD and requires baseline oxygen, and if they have an increased oxygen need due to COVID-19, they would also not qualify. This hospitalized for COVID-19 criteria is always a little funny because it doesn't necessarily mean that hospitalized patients cannot receive this drug. It only means that hospitalized patients who are hospitalized for COVID-19 cannot get this drug. So if you have a patient who comes in for, say, a hip replacement or appendicitis and on screening is found to be COVID positive and is exhibiting mild symptoms, that's when you can give this drug, because the assumption is if they weren't here for their hip replacement, they would not necessarily have been hospitalized for COVID-19. Here's also the criteria for post-exposure prophylaxis. So you have to be either not fully vaccinated or not expected to mount an immune response and have some type of exposure. So for that criteria, you either have to have been exposed to an individual infected, so a single high-risk exposure, or you could be somebody who works in a facility or institution where there is always ongoing exposure. So for instance, a nursing home, prison, a long-term care facility, a infusion clinic. And so if the healthcare provider or the healthcare member of the healthcare team is not fully vaccinated or is vaccinated but themselves have some type of immune compromising condition and is continually exposed, they qualify for this post-exposure prophylaxis. And this criteria is the one that allows them to get that monthly dose. So the question we always get is, what is considered high risk? So this is a little bit of a nebulous definition. And on the right-hand side here, you can see I have the criteria for identifying high-risk individuals. And this is straight out of the EUA for Casirivimab. And you can see that the list is fairly extensive. And with each revision of the EUA, this list has gotten longer and it's gotten more inclusive, which is a good thing. But you can see there are many conditions that are not explicitly defined, such as chronic kidney disease or diabetes or immunosuppressive disease. So what does that actually mean? And this can be somewhat at the discretion of the provider, which I think sometimes makes it difficult because it's up to interpretation. So it's in these settings where having institutional guidelines is very helpful to standardize prescribing across services. So for instance, at our institution, we have defined chronic kidney disease as a creatinine clearance less than or equal to 45. And diabetes, we consider diabetes requiring any type of medical treatment. So that could be insulin or an oral anti-diabetic. What I want you to be aware of is on the bottom here in the last paragraph, there's a statement here that I think is really important. Other defined in the EUA. And this statement about race or ethnicity is particularly important. So being a African-American or Latino definitely puts you at higher risk, and that is enough to qualify. But it doesn't necessarily need to be limited to those two scenarios. So other high-risk criteria could be something like living in a congregate facility, homelessness, substance abuse, etc. So I find this slide to be very helpful. So this is a slide that is used to define moderately to severe immune compromised people and is the definition used for criteria for the third dose of the Pfizer or Moderna vaccine. And I like this slide because it allows us to apply essentially the same criteria over to the monoclonal antibodies, and so that we are consistent across all our COVID therapeutics. And so this is actually fairly specific, even to the point where it's telling you what level of your CD4 count is considered immune compromised for HIV, and what dose of steroids is considered immune compromising. So this is a good reference that we use when we talk about immune compromised patients. So I wanted to finish with a last couple slides looking at the data for how Casirivimab and Imdevimab got its EUA authorizations. And again, it has two indications, one for treatment and one for prophylaxis. And I have the treatment on the left-hand side and the prophylaxis on the right-hand side. Interestingly, the treatment data has still not been published, but is still available on their website. This was a phase 3 study looking at outpatients within 3 days of COVID diagnosis with at least one risk factor for severe COVID-19. In this study, they actually looked at 2 different doses of Casirivimab and Imdevimab. They used the high dose 2,400 milligrams, which was the dose that was in the original EUA. They also used the 1200 milligram dose, which is the current EUA dose for treatment and prophylaxis, and it was studied against placebo. And from their findings, you can see that there was a 70 to 71% in relative risk reduction in COVID-related hospitalization and death. And the 70 to 71% depends on whether or not you're looking at the 2400 versus the 1200. So this is part of the reason why the dose was changed from 2400 to 1200. It wasn't very different between the two. There was a faster symptom resolution from 14 to 10 days compared to placebo. And for deaths, you can see that it was fairly rare in either case, but it was 2 in the Imdevimab group and 5 in the placebo. There was a modest reduction in viral load in this study, which I did not find too compelling, but I did find the adverse effects to be very interesting. So you can see serious ADEs were very, very low to begin with. This is then in contrast to the prophylaxis study, which was just published a few weeks ago in New England Journal of Medicine. So this was also a phase 3 study, and it was done in asymptomatic healthy household contacts of a person who had a diagnosis or known positivity to SARS-CoV-2 infection. So this was the post-exposure prophylaxis study. In this study, they looked at Casirivimab, Imdevimab, 1200 milligrams Subq versus placebo. So they split the findings into symptomatic versus asymptomatic COVID infection. And you can see that there was a 81.4% relative risk reduction in symptomatic cases. And there was a 66.4 relative risk reduction in the of viral load was significantly different. So 136 weeks in the placebo to 14 weeks. So a very, very large decrease in viral shedding, which again has public health significance. And lastly, you can see the adverse drug events listed below, and we're going to dive into this a little bit deeper. So here are the adverse events with the Subq administration. This is the data from the single dose Subq study that was published in New England Journal. They classify adverse events as essentially any type of poor outcome, which included the COVID-19 diagnoses, headache, and injection site reaction. This isn't all of the adverse events. This is just the most common ones. So you can see injection site reaction occurred in 4.2% of patients compared to 1.5% in the placebo group. This is with the single dose 600 Imdevimab Subq dose. There was also in the EUA data on repeat injections for the repeat patients. And in that group, they did not use the lower dose. They used the 600 again. And you can see that the injection site reactions were twice as high as placebo. And it's not insignificant at this point. It's 35% versus 16%. Thankfully, the EUA actually has the repeat doses now at the lower dose. So hopefully this will be not as significant. And notably, there were 8 instances of hypersensitivity reaction in the Regen-Cove group. There were none in the placebo. And there were no cases of anaphylaxis.
Our next segment will be presented by Dr. Sarah Edgerly. Dr. Edgerly graduated with her PharmD in 2008 from the University of New Mexico. After working as a pediatric pharmacist at Oregon Health and Science University, she went on to complete a PGY1 residency at the same institution. She has experience in drug information, rheumatology, pediatrics, and now works as a monoclonal antibody pharmacist in a clinic for COVID-19 positive patients at the University of Kentucky. Sarah will be discussing monoclonal antibodies, observation, and emergency response. Dr. Edgerly, I turn it over to you.
Thank you so much, Mike. Okay, we're going to start by just talking about the different formulations for this medication. As you can see here, this is a combination vial. It is the co-formulated 10 ml vial that contains both of the medications within. It's going to be 1 vial per patient. And you're going to withdraw 2.5 mils into 4 separate syringes for this. The total for this one is going to be 1,200 milligrams. It'll be 600 milligrams of Casirivimab and 600 milligrams of Imdevimab. The other 2 formulations that we have are individual vials. The first one is an 11.1 mil vial, and that is going to be for 1 singular drug. There's going to be enough for 2 patients within this vial. So you'll still be able to withdraw 2.5 mil vials into 4 different syringes, but you're actually going to use that for 1 patient and then your next patient. So when you're drawing that up, you're going to want to make sure that you have less than 4 hours between your next patient. Otherwise, you're going to have to throw one of those doses away. And then the last one down here is just the single dose vials, the 2.5 mil vials. Each of them are going to contain 300 milligrams of the single entity drug, either Casirivimab or Imdevimab. And again, you're going to withdraw for the 11.1 mil vial, it'll be 2.5 mil injections for each patient. And then if you're using the 2.5 mil vial, you'll just withdraw 2.5 mLs, and you'll do that 4 times. So when you're using the individual, you'll have 2 doses of Casirivimab and 2 of Imdevimab for each patient. You're going to want to allow your product to warm up to room temperature. This usually takes about 20 minutes. You can either do that by taking the vial out of the box and just laying it on your desk, or you can do that after you withdraw the drug into the individual syringes. You're going to want to be careful not to shake it or expose it to heat, so do not warm it up in your hands. Also, take note not to flick the side of the syringe. Sometimes, you can get bubbles when you withdraw the medication. What I usually do is I just push the medication back into the vial with that syringe instead of flicking on the side of it. We just don't want to damage, any of the molecules in the drug. Once you withdraw your syringes, you can store them for no more than 4 hours, and that's going to be either at refrigerated or room temperature. It honestly doesn't matter which you choose. If you do decide to place it in the refrigerator, make sure that you give it time to warm up for, again, about 20 minutes before you administer it to your patient. And just really quick, if you're going to be doing post-exposure prophylaxis and you happen to have a patient that you're doing repeat dosing on, just take note that the dose is actually going to be half of what it is for the treatment. So it will be 300 milligrams of each component instead of the normal 600 milligrams of each for treatment. So per the federal response to the COVID-19 monoclonal antibody clinical implementation guide, which I've referenced down here at the bottom of the slide, monoclonal antibodies may only be administered in settings in which healthcare providers have immediate access to medications to treat a severe infusion or hypersensitivity reaction, such as anaphylaxis, and have the ability to activate the emergency medical system as necessary. Some of the requirements for use under the EUA, patients must be monitored for at least 1 hour after the completion of the infusion or the injections. Education should be provided to every patient regarding medication information, CDC isolation guidelines, and red flags for seeking emergency care. Also, serious adverse events must be reported to the FDA within 7 calendar days. I really would recommend taking the time to read over the criteria for serious adverse events. Hospitalization is actually considered to be a reportable occurrence. So if you administer the medication to your patient and 2 days later they continue to decline, even if it is progression of COVID, you actually do have to report that to the FDA. They are tracking all of those hospitalizations. So for monitoring, you're going to want to develop a monitoring protocol for your institution or clinic. Always take vitals before, immediately after your injections, and again at 1 hour after administering those injections. At our institution, we use a Dynamap, which you can see right here, and it's extremely helpful for obtaining all of those vitals. We get a temperature, blood pressure, heart rate, and oxygen saturation, and the respiratory rate of the patient every time we do the vitals, with the exception of temperature. I usually only take that at the beginning and then again at the end. Depending on how your clinic is set up, if your patient is in their own room, you're going to want to have a system in place where they can contact you if they experience any reactions, if they need to go to the bathroom, need a warm blanket. The way that our clinic is set up is we're basically in a hallway, and each patient has their own room. We do not move the patients around from room to room. Like, we don't have a place where we do the injections and then take them for observation. They just stay in their room the entire time. And we have a bell that we've placed in each of the patient rooms, which has been really helpful. If they need us, they're able to just ring the bell. We can hear them and go in and see what they need. Another option would be having a phone in the room with a number to call into your office. So injection-related reactions, these are usually going to occur within the first hour of administration. Most commonly, you're going to see them within the first 15 to 30 minutes. Reactions can be delayed, and rarely, sometimes they've been reported after 24 hours have passed. Is a lot of fluid to go into one place. And so this likely contributes to the discomfort that the patients will experience. Usually the pain is only there while you're administering the injection, and once that injection is completed, the pain does subside. The injection technique that you have can actually play a substantial role in the amount of discomfort that your patient experiences and how they respond overall to you. So some tips on providing an injection. You want to landscape the area before you administer that injection. And what I mean by that is take some time to actually look where you're going to go first. I will usually take a look at the back of the arm and just kind of feel around to make sure I'm not going to be injecting into a bruised or scarred area. You also want to avoid any wounded areas or areas with tattoos. Most commonly, the injection sites that we use are going to be the back of the upper arms. Take care to avoid the bottom part of the upper arm towards the elbow. There really is not a lot of subcutaneous tissue there, and it can actually be quite painful if you were to administer it there. So you really want to try to go up here, right in this back area. Also with the abdominal area, that's another area that we can use for an injection site. And you want to avoid the waistline for obvious reasons, as well as 2 inches around the navel. There actually are fewer nerve endings at the very low part of your abdomen. So I usually do lower abdominal injections when I give them, and the patients seem to tolerate them a lot better. Oftentimes they will say that they do feel the poke a little bit more in the abdomen than they do in the back of the upper arms. And so I'll just, let them know before there's going to be a little poke that they're about to get. But usually the abdomen area is very well tolerated. And then the last place is the upper mid to outer thigh. Usually we'll do this for our pregnant patients. They, for obvious reasons, don't want the injections to be done in their abdominal area. So we'll typically choose one in each of the back of the upper arms and then one in each thigh. So when you are doing your injections, this is especially true for the upper arm injections, make sure that you don't inject too shallow into that subcutaneous tissue. If you do that, it's essentially going to be an intradermal injection, and it can be extremely painful. You will know if you have gone into the intradermal space because the skin will actually begin to bubble up. And oftentimes your patient, they're going to wince and you're going to hear them audibly say that this one really hurts this time, or something to that effect. So really you want to go in at a 45-degree angle when you do the upper arm. If you have a patient who is a little bit larger and has some more subcutaneous tissue there, you can go in at a 90-degree angle. I usually, as a general rule, think of the arms with the 45-degree angle, and then the abdominal area and upper thigh to be a 90-degree angle. So just take care when you're doing that you don't go into that intradermal space. Also, you really want to have the patient relax their arm as much as possible prior to inject. An H1 antihistamine such as diphenhydramine or cetirizine, as well as a blood pressure monitor. And this monitor can be either manual or automatic. Epinephrine should be given as soon as features of anaphylaxis are present. Do not be afraid to administer epinephrine if your patient is truly experiencing anaphylaxis. The sooner you give this medication, the better the outcome is going to be for your patient. Always remember that intramuscular is the preferred route for anaphylaxis. So even if you have a patient who has IV access, you do not want to administer epinephrine IV for anaphylaxis. Generally, anytime IV is used for anaphylaxis, it is reserved for refractory situations where the patient has not responded to the IM injections, and that's oftentimes going to be in like an emergency room setting or something like that. There are cardiac complications that can occur if it's accidentally given IV, so it's always just best to remember to do that intramuscular when you're treating anaphylaxis. At our institution, our hypersensitivity kits contain a 50 milligram vial of diphenhydramine, a 100 milligram vial of hydrocortisone. We have an albuterol MDI in all of our kits and 3 auto-injector EpiPens. The 0.3 milligram EpiPens are completely appropriate for pediatric patients who fall under the guideline for this EUA because they're all going to be over 40 kilograms. So you don't need to worry about having EpiPen juniors available as well if you're going to be servicing pediatric patients. Some optional medications and emergency equipment to have available. Not every place is going to have all of these. We do not have all of these at our site, but truly it is best practice to have as many as you can. A pulse ox really honestly should be used at every single site. If you're using a Dynamap, it will be in there, which is one more reason to use a Dynamap. Oxygen is also something that's recommended, bronchodilator, such as albuterol, an H2RA, such as famotidine, corticosteroids, an intubation kit, intravenous fluids, or a CPR mask. Also, one important consideration to remember is that the PrEP Act does not add authorization for emergency medications. So you're really going to want to consider your state scope of practice and your individual protocols regarding that. So healthcare personnel should consider anaphylaxis when patients present with generalized signs or symptoms such as hives, serious or life-threatening symptoms such as hypotension, respiratory distress, or significant swelling of the tongue or lips, or symptoms that involve more than one body system. So anaphylaxis requires immediate treatment, and the diagnosis primarily is based upon the recognition of clinical signs and symptoms, which you can see listed here. As I said previously, symptoms usually occur quite quickly, often within the first 15 to 30 minutes of administration, although rarely it can take up to several hours for symptoms to appear. Early signs of anaphylaxis can resemble a mild reaction, and it's often really difficult to predict whether or not the initial mild symptoms are going to progress to a full anaphylactic reaction. Not all of the symptoms that you see listed here are present during anaphylaxis, and not all patients have skin manifestations, although typically you will see cutaneous involvement when someone's experiencing anaphylaxis. Alternatively, some of the symptoms listed here may not always indicate anaphylaxis. So really it's important to evaluate your patient as a whole when you're trying to determine whether or not they are experiencing that. Here's a nice little diagram. Anaphylaxis typically is highly likely when one of the three following criteria are fulfilled. For our purposes, we're really going to talk about this first and second one. This bottom one that you see here, where it talks about reduced blood pressure after exposure to a known allergen. You're going to see that most often with bee stings, penicillin allergies, other medication allergies that are known to the patient. So we're really going to discuss just the first and second one on this slide. So it's going to be a sudden onset of illness, which is usually minutes to hours, usually with involvement of the skin, mucosal tissue, or both. You can see on this patient right here, he does have a rash on the vast majority of his body. And then usually you're also going to have at least one of the following. So you'll have sudden respiratory symptoms and signs, or a sudden reduction in blood pressure or symptoms of end organ dysfunction. On the second one here, this is when you can have multiple organ systems involved and not always see this skin or mucosal symptoms. So again, here we have these skin manifestations, respiratory symptoms, sudden reduction in blood pressure. And then this last one, this sudden gastrointestinal symptoms. When a patient is experiencing anaphylaxis, you do have quite a bit of histamine that's released throughout the gastrointestinal tract. And so patients can present with abdominal pain and vomiting. So if you have a patient who is beginning to vomit, complaining of abdominal pain, and they have a sudden reduction in their blood pressure, you really do want to suspect anaphylaxis in that instance. So if anaphylaxis is suspected, you're going to want to call EMS, always call 911. Place the patient in a supine position, face up with their feet elevated, unless that patient is vomiting or experiencing upper airway symptoms. Always administer epinephrine immediately. Again, never be afraid to give epinephrine if your patient is truly experiencing anaphylaxis. It really can save their life, and the sooner you give it, the better the outcome will be. You're always going to want to use a 1 milligram per ml concentration and administer 0.3 milligrams intramuscularly into the mid to outer thigh and through the clothing if necessary. This is when those Epi auto-injectors become very helpful. If you've never used one before, I would really encourage you to familiarize yourself with those and how they work. They are designed to be given right through the clothing, so you don't have to worry about removing any clothing in order to access the skin of the patient. They should always be administered into the mid-outer upper thigh. This is because the anterior lateral thigh really is the biggest, most vascularized muscle in the body, and you're going to have rapid absorption and high plasma concentrations of epinephrine very quickly after you administer that. Usually you will see a maximal efficacy within 10 minutes after administering into that area. Be sure to, when you're using the Epi auto injector, place that. You're going to need to hit it really firmly actually, and hold that in place for about 10 seconds to make sure that all of the medication actually makes it into the patient. This can be repeated up to 3 times every 5 to 15 minutes. 5 minutes is an extraordinarily long time if your patient is experiencing anaphylaxis and having a hard time breathing. So really, If you've given a dose of epi and your patient still is having a hard time breathing after 2 minutes, it's okay to go ahead and give that next dose. Oftentimes as well, if you have to administer 2 doses, if they don't respond to that first dose, you're probably going to have to administer a 3rd dose. One note that I just would like to mention is antihistamines really should never take the place of epinephrine in a true anaphylactic situation. Epinephrine works by stimulating the beta-2 receptors, which cause bronchodilation, and they also stabilize mast cells so that they can no longer release large amounts of histamine. So when you're administering epinephrine, you really don't need to pre-treat with an antihistamine like Benadryl. Also, important to remember that there is no contraindication to receiving epinephrine in the setting of anaphylaxis. Some additional considerations with monoclonal antibodies, it's very common to be able to reverse the hypersensitivity reactions with medications. And with this specifically, I'm not necessarily talking about anaphylaxis. I'm talking about just a true hypersensitivity reaction where the patient is experiencing a rash or something like that. Given back and wish that you would have contacted them earlier. One important thing I'd like to talk about that is a little bit not necessarily related to hypersensitivity reactions. Not all providers that refer patients to you are going to see their patient before they come to your clinic. And so some of the things that we've seen is some of our patients are very ill when they come to us, and they might actually need to be sent directly to the emergency room without receiving treatment. I have 2 patients that stick out in my mind. One of them was statting in the low 70s. The other one was in the low 80s. And he actually was in full-blown shock when he presented to us. And so we did call 911 and had him sent to the hospital. He was intubated pretty quickly upon arrival and was admitted to the ICU. So really, you're going to need to utilize your clinical judgment when you're evaluating one of your patients, especially if they have a low oxygen saturation or a high respiratory rate. You just look at the patient overall, and if the patient really does seem too sick to you to be in your clinic, never hesitate to reach out to the provider. And if you can't get a hold of the provider, it's definitely not wrong to refer them to the emergency room. So a quick note on anxiety and panic attacks. Some patients are understandably quite nervous when they come into the clinic, and honestly, it's very common for them to have a slightly elevated blood pressure, especially after they realize that they're going to be getting 4 separate large volume injections. Patients who are prone to having panic attacks or who have a really high needle anxiety, they may be more likely to experience some rapid breathing and describe feelings of heaviness on their chest. Honestly, it can sometimes look very similar to a hypersensitivity reaction. It's really important to help your patient relax as much as possible in order to help prevent an anxiety attack that can look similar to this. Some techniques to help calm your patient down. It's really important to talk in a calming voice, engage your patient in conversation, talk with them a little bit, get to know them some, help them to relax before you start to give those injections. The more comfortable your patient is with you, honestly, the better they're going to do with these injections overall. In the event that your patient does experience some type of lightheadedness or dizziness after their first few injections, which actually is not uncommon at all, go ahead and just pause the injections and just talk with them. Talk with them about something non-COVID related. Talk with them about the weather, about hobbies, what they like to do when they're, not sick with COVID. Just talk to them about anything that can really help them to get their mind off and calm them down. Usually what you'll find is when you do this, the patient will really be so much more relaxed, and the next 2 injections, it's just going to be so much easier for them. If you have a patient chair that can be reclined, consider allowing that patient to lie back. That can really also help with helping to relax the patient when they're very nervous. Also, ice cold water to drink and a cool wet rag on the forehead. This does not have to be a rag. It can also be, a paper towel. If you have paper towels in your room, just get it wet and fold it up. And that really can help to decrease patient anxiety and help them relax overall. One additional consideration to think of, if you are working in a clinic by yourself, it's so important to never leave your patient alone for any amount of time. And I know this is kind of an odd thing to put in this presentation, but we are pharmacists, we're not nurses. So really, we don't think like nurses do, and which is fine. But in this instance, ours originally, I was the only person in the clinic, and it was very hard. I was doing everything from registration to verifying orders and pulling up the drug, monitoring vitals. It was a lot of work. So if you're just starting your clinic, I would really recommend having at least 2 people there from the very start. So the PrEP Act Declaration Amendment does require compliance with record keeping and reporting requirements for the jurisdiction that you're administering these therapeutics in. And this includes informing the patient's primary care provider when available, as well as complying with requirements with respect to reporting adverse events. So essentially, anytime your patient is having a hypersensitivity reaction, you need to let that patient's primary care provider know, in addition to reporting that to the FDA. As we've talked about, all severe adverse events have to be reported through FDA MedWatch as defined in the EUA. And I've put that website here on the slide. You can also find that in the EUA, and there's a hyperlink just to click, and it's quite easy to do, actually. And so lastly, I just want to say thank you to all of you. Whether or not you realize it, you really are a hero in the way that you're stepping up to take care of patients. And honestly, this is something that we don't do often, like I said before. And so the fact that you are willing to do that and step up and help so many people really speaks volumes about you as a healthcare provider and as a person. I think we really, as pharmacists, have a chance to make such a profound impact right now with the way healthcare is. It's been a really hard year and a half for everybody, but I think we are going to look back on this and really be proud of the way we were able to help patients. So thank you very much.
Thank you, Dr. Edgerly, for that comprehensive review of infusion or administration reactions to Casirivimab and Imdevimab and the appropriate emergency response. Let's move on to our conclusions. But first, let's return to our self-assessment questions. Our first question was, which of the following are COVID-19 monoclonal antibody indication and route combinations currently authorized under emergency use? A, Bamlanivimab and Etesevimab, given subcutaneously for COVID-19 post-exposure prophylaxis. B, Casirivimab and Imdevimab given intravenously for COVID-19 pre-exposure prophylaxis. C, Bamlanivimab and Etesevimab given intramuscularly for COVID-19 treatment. Or D, Casirivimab and Imdevimab given subcutaneously for COVID-19 post-exposure prophylaxis. And hopefully you'll all recall from Dr. Yang's presentation, the correct answer is D, Casirivimab and Imdevimab given subcutaneously for COVID-19 post-exposure prophylaxis. The combination Bamlanivimab and Etesevimab are not authorized for subcutaneous administration, and Casirivimab and Imdevimab are not authorized for pre-exposure prophylaxis. And similarly, Bamlanivimab and Etesevimab are also not authorized for intramuscular administration. Our second question was a case. A 20-year-old female received a positive SARS-CoV-2 result from your institution. You're following up on the results to determine if she meets criteria for COVID-19 MAB therapy. Her medical history includes an appendectomy 2 years ago and type 1 diabetes. Should you call the patient to recommend MAB treatment? No, she is too young to meet MAB treatment criteria. No, her medical history does not make her eligible for MAB treatment. Yes, a medical history that includes diabetes makes her eligible for MAB treatment. Or D, there is not enough information to determine her eligibility for MAB treatment. And the correct answer is yes. Having a medical history that includes diabetes makes this patient eligible for MAB treatment. And hopefully you'll recall from Dr. Yang's presentation the list of conditions that may make a patient at high risk for severe COVID. Our final self-assessment question is, which of the following are potential signs and symptoms of an infusion or administration reaction to MAB treatment? A, wheezing, B, nausea, C, dizziness, D, erythema, or E, all of the above. And hopefully you'll recall from Dr. Edgerly's portion of this program that E, all of the above, is the correct response. So in conclusion, COVID-19 monoclonal antibodies may be used for post-exposure prophylaxis and treatment of COVID-19, and this depends on the specific combination monoclonal antibody and the emergency use authorization for each of them. COVID-19 MABs should be ordered and administered according to indications and contraindications in the EUA or licensed prescribing information. And finally, patients who receive COVID-19 MABs should be monitored for infusion or administration reactions, and emergency medications should be available. Here are some recommended resources from this presentation, including the COVID-19 PrEP Act Declaration 9th Amendment and some information from HHS. And this concludes our program. Thank you for participating.